My name's Mark Boyd. I'm the Chair of Medicine at the University of Adelaide, based at NALHN. And I'm also an infectious diseases physician. And as the Chair of Medicine at NALHN, it gives me great pleasure to welcome you to this Adelaide Biomed City Research Mini-Review. I'm very happy to introduce two well-known researchers from NALHN. And I'll introduce both of those people in a minute. I would instruct the audience, if you have questions, please type those into the Q&A section in the Zoom chat, and I will make sure I ask those questions to each researcher. That will be my responsibility. I'd also like to acknowledge that we're on Kaurna country. That's where I'm speaking from, and the Northern Adelaide Local Health Network acknowledges the Kaurna people as the traditional custodians of the land where we proudly work and deliver health and wellbeing services. We also honour Kaurna elders, past, present and emerging, and we recognise Aboriginal cultural authority and their ongoing spiritual connection to country. So this session is being recorded, by the way, and will be available on the ABMC website shortly after this session is completed in the next few days. And I'd like to introduce two speakers today, Professor Rajvinder Singh, and also Associate Professor Rohit Joshi. And we've got Professor Singh presenting first on the advanced endoscopic detection and treatment of early gastrointestinal tract cancers. Raj, please take over and welcome.
Thanks, Mark. So I'll just get my slides ready. Can that be seen, Mark?
Yes, that's good. Very good.
Thank you. So thanks, Mark, for the kind introduction, and thanks to the ABMC for this invite. I'm pleased to be here together with Rohit. So I'll be talking on advances in endoscopic imaging and resection in the gastrointestinal tract or the GI system. So this is sort of the brief of my talk, which will include advanced mucosal imaging. So looking at lesions before we undertake certain procedures, including a wide field endoscopic resection, something called endoscopic submucosal dissection, a bit on computer aided diagnosis, and something which is coming to the fore, which is called third space endoscopy. I will not be discussing organoid culture, which we've got some collaborations with the CSIRO. So I'll go on to my next slide, which is on endoscopic imaging. And this is the evolution of endoscopy. And in the good old days, we used to use a gastro camera with what was sort of a fiber optic type system with an eyepiece. And that slowly moved on. And in this instance, you can see a video scope with probably what appears to be an early esophageal cancer. In the 2000s, with the evolution of more and more imaging, you can actually see the same lesion, but now seen very clearly. And in this day and age, we can also magnify the surface structure to look at the vascularity or the vessels which are feeding the early cancer, as well as the cell structure. So this is just a basic standard endoscopy of the stomach, and I hope you can see this. Basically, the scope or the device being pushed beyond the stomach into the small bowel or the duodenum. So what I'll be discussing is certain elements of mucosal imaging, looking at the surface of the GI tract with chromoendoscopy, a push button technique called narrowband imaging, and a more magnified like system called confocal endomicroscopy or endocytoscopy, and how this will help us with endoscopic treatment. So this is just an example of an esophageal squamous cell cancer. And in this instance, this is the gullet or the esophagus, and you can there could be some evidence of what appears to be reflux disease here. This is more clearly seen with narrowband imaging, and the surface structure, which tells us that this is actually not reflux, but an early esophageal cancer. And this is what's called as chromoendoscopy, where we put in a bit of iodine on the surface and we can really clearly delineate the early cancer, which is then removed with the scope using a minimally invasive technique called endoscopic resection. In Barrett's esophagus, which is another pre-malignant condition in the esophagus, sometimes we can miss very early cancers, such as in this instance in the corner here, the 3 o'clock position. This was an early cancer which could have been missed if just biopsies would have been taken randomly across the esophagus. So narrowband imaging is a push button technique, and together with magnification, we can actually look at the surface structure. So this is just an example of narrowband imaging by NBI on the right. And certainly if we magnify this mucosal tongue, as we may say, we can look at the pattern and the vascularity there in greater detail and then predict histology. So we have done this with various studies, including this in Barrett's, which is probably about 14 years old now, looking at cancer versus what's called as non-dysplastic regions on the left-hand side. We can also look at endocytoscopy, which is actually a microscopic level of magnification up to 500 times. In this instance, this is the views we get, which a pathologist would get looking at cellular type structure in real time. So these are real living cells being imaged here in this video. In the stomach, more or less the same sort of structure can be seen. And these are all, again, highly magnified images, but this is what we have been doing over at the NALHN McEwen Hospital for the last 14 years. And we can clearly see areas which are abnormal, as you can see with the arrows pointing. The central area is abnormal versus the periphery, which is normal. So in the duodenum, this is just an example of cytoscopy being used. These are villi, villus-like projections, which helps with absorption of food or diet. And we can actually see these fantastic images of magnification with nuclei actually seen in this villi. So how do we remove lesions? Once we have detected them, we try to get underneath and around lesions, as you can see in this cartoon, and try to resect them. This is just an example of quite a large lesion in the colon. It's obviously not a cancer yet, although in the past, perhaps 3 or 4 or maybe 5 years ago, this would have been removed surgically. In this day and age, we can remove it using various endoscopic type techniques. And you can see in this video that the whole lesion has been removed. This extends probably over a few folds, maybe measuring about 6 to 7 centimeters in size. So we normally do about, or we remove about 200 of these lesions a year, and this is from the entire GI tract. In this instance, this from just from the colon, and an audit we did about 3 or 4 years ago. A lot of these patients do not need to be hospitalized. Only about 7.5% of patients are hospitalized, and the rest can go home on the day of the procedure. This has led to quite significant cost savings as well as bed days saved. And we have collaborated with a few centers across the world, leading to various publications in some minor gastroenterology related papers, including one simply named gastroenterology. So these are some of the papers, and we basically have sort of led the world with regards to the number of patients whom we have in our cohort. It's now touching about 5,000 patients over the last 14 years compared to the other centers, as you can see them. So we can also remove early cancers in a single piece, and this is called endoscopic submucosal dissection, where we mark around the early cancer. In this instance, it's in the stomach. And then we use something called a needle knife to cut it all in a single piece. So you can see that this video shows how the resection is being performed. And you can see that in this instance, entire lesion has been removed. And this is in a single piece, which is pinned on a cork for the pathologist to look at. This is just an example of computer-aided diagnosis, which we are also using nowadays to try to investigate its capability. and it allows us to actually look at the surface structure and the computer tells us what we're looking at. So this is some of the work which we've been doing. And I'll just touch on third space endoscopy, where we're able to use the camera to get outside the GI tract to sort of induce a perforation to treat things. And this is used for a condition called as achalasia of the cardia, where we try to tunnel within the esophageal wall. So that's the muscle over there. And then slowly cut the wall with the device. And then once we have done that, the mucosa or the lining is intact. We just close that with some clips. And these patients get admitted for a couple of days, then they go home with no issues with regards to swallowing on follow-up. So these are some of the things we can do. We can also sort of deal with devices which enables us to stitch things. This is just a stent being put and then a stitching device being used to stitch a stent in place. And this is coming to the fore as well. And we're quite facile with this device. We've been using it for the last 4 or 5 years. So this is in conclusion what the group has done on a whole, which includes finding lesions, either they're pre-malignant or malignant, so advanced mucosal imaging, and then using some of the techniques, including AI, artificial intelligence, to try to remove these lesions, either using a wide field endoscopic mucosal resection technique, which is a minimally invasive treatment strategy. Patients go home the same day, or an ESD technique for early cancers, where patients may remain in the hospital for a day or two, compared to surgery, which could be up to a week or more. Then we're also able to now get into the third space, as well as using certain devices to stitch things together. So these are some of the advances which we have done, and hope to collaborate with interested parties out there. There's a huge repository of images, and including samples which can be accessed for further work. And as I said, I've not touched on organoid culture, but this is something which we are doing as well. So thank you very much, and I'm happy to take questions.
Fantastic presentation, Raj. I've seen your presentations a number of times. I always make a case because they really are spectacular and very compelling. I think I've got one question. We probably only got time for one question, but John Beltrami asked, what is the complication rate for the endoscopic biopsies and tumor resection?
So it depends, John. Thanks for your question. So with regards to endoscopic mucosal resection, the complication rate is about 1 to 2%, based on the data which we have actually published over the last many years. The most evident or worrisome complication is a perforation, which is about 1%, and that generally can be identified during the procedure and sort of sorted during the procedure with either clips or with the stitching device which I showed. The more sort of common complication is delayed bleeding. So bleeding which occurs during the procedure can be again sorted with the scope and various devices, but bleeding which occurs after or towards the later state when patients go home can occur in up to about 5 to 6% of the time. And these patients sometimes get admitted, maybe needing a repeat scope, perhaps not. For the ESD technique, the complication is a little bit higher because we use needle type devices, and it's a millimeter by millimeter dissection. But the outcome is certainly better for these patients if we remove lesions within a single piece for the pathologist to look at.
Okay, look, I have a couple more questions, Raj, but I think perhaps what we should do is switch now to Rohit to give him time to talk, and then if you're able to stay on, we have time at the end, I might ask those questions. Is that okay?
Yeah, that's fine. Thank you. Thanks again.
Okay, so without further ado, please welcome Rohit Joshi, and he will present on setting up a cancer research unit and what we are doing there. Rohit, please take over.
Thank you for that. Can you see the screen and can you hear me?
Yes, everything's good.
Okay, good. Well, thank you so much for this opportunity. So I want to thank Professor Beltrami and to Cara for this invitation, and the Adelaide Biomed precinct and everything else there. So I was going to speak a bit about the birth and evolution of a cancer research unit. So we sort of set up a unit up at the LAHN, and then we sort of decided to move something slightly different in the city. So this unit is based in St. Andrews. It's a few of us who sort of set it up together. And I guess the big question is, why would you do it? So I guess for most of our patients, they run out of treatment options. And also we're giving people and their families hope for something more than over and above what's normally available. And I guess why did we set up our own? I think we wanted the freedom, so we want to try and break away from bureaucracy sort of in bigger hospitals and units in that respect. The other thing was that not many places allow us to do early phase work, which is first in human work. So we wanted to set up something which we can do on our own terms. So who are we? So there's sort of 4 medical oncologists. So me sort of in the middle there, standing is me and Vineet, the other doctor sort of sitting there. We both work in NALHN and the LAHN. Savan Bishnoi and Meena, so they both work at Icon in the Royal Adelaide. This is the entire team, and this has all sort of happened in the past sort of 6 to 8 months. And everyone sort of has come from different parts of the state to come along and join us along with what we do. So that's sort of the team that's there. So essentially in October 2020, the proof of concept was sort of thought about by a few of us. In Jan 21, Kelly joined us as a research manager. She came to us from Flinders. She was second in command there. In Feb 21, we moved into a single room office at the back of one of the surgeon's offices. We ran out of space within sort of 2 or 3 months, and we moved into a larger office on Hutt Street. And in September, pretty much a month later, we opened our first phase 1 study. So in terms of vision, we sort of sat and thought what we can do different about it. And I think the idea was to provide excellence in cancer care. And the idea was to bring people together through innovation, leadership, and collaboration. And I guess, you know, we're pretty passionate about the mission that we sort of try and do. And the primary idea is to bring world-class cancer research to our community and to provide leadership in the treatment and care of cancer through research, excellence, and innovation. So we sort of went about spending a bit of time making a logo. And this logo sort of took a bit of time to make, but essentially, if you look around the place, each of the cancers have got a different color or some sort of ribbon to it. What we decided was we put them all together into a single logo, and it was sort of originally meant to be like 4 partners over there. So there's 4 people standing together, trying to help things together and help people together. And that was our sort of in line with our vision to bring people together in collaboration. So each of the different colors, you know, signifies each type of a cancer. And that was the idea of trying to make this together. We found a few barriers when we initially set it up. So one of it was we had absolutely no idea how to set up or start a business. Like none of us had a clue. We didn't really have 2 people to help us guide us. And I guess all the costs were coming out of our pocket. So we didn't really know what else we could do differently. There's a lack of trained staff in research across the state, actually across the country. And there's 4 of us who are sort of full-time medical oncology consultants. None of us had that much of time to spend. But I guess the thing for us was to try and see if we can sort of think differently, not just sort of try and do something slightly different, but to think something completely differently. So we did things like all of our purchasing was off Facebook Marketplace or Gumtree or Amazon, because we didn't really have the money to go and buy fancy stuff. Our unit is completely paperless, so it's all digital stuff and online forms. We've got a couple of waste bin baskets in the entire thing, and that's it. Everything is all paperless. We use all electronic communication, whether it's Teams or SharePoint or online browser-based stuff. Just to give an example of, like, for example, NDN, when we sort of took our place on Hutt Street, it was the only place in entire Hutt Street which actually had no NBN for some strange reason. And we spoke to every person who was in town, couldn't get across. Ultimately, we sort of sent a mail off to Andy Penn, who's the Telstra CEO, just for the heck of it. He responded back, and 3.5 weeks later, we got NBN. So it's just pretty cool to think out of the box. So what do we do? So we're doing phase 1 work, including first-in-human studies. There's not a lot of places in South Australia which do first-in-human studies. We sort of do a fair amount of intensive PK work and do that for us things. We also do phase 2 and phase 3 studies. And we sort of try and generate a list. Now, this list sort of ties up with the rest of South Australian clinical trials on a single thing, which goes through the Cancer Network, through Dr. Ganeshan across the state. What's the impact that we have made? So as of now, we've got sort of 12 staff. We've got global collaborations. We've got 21 open studies. And I think by October, we'll have 31 studies open. We work with large pharma, small biotech. And I think we're bringing business to South Australia, which is usually reserved for Sydney and Melbourne. So we're sort of opening up completely new chapters for our state. We're also sort of found that there's a way to get research and development tax rebates. So if people come to us from overseas, we can actually help them out with tax rebates in what they do. We've also managed to get in touch with the Department of Trade and Investment, and they have been sort of very nice in helping us out negotiate things. Also, in terms of some studies, so we opened a study called Suplexa, which is using, it's like as if using CAR T cells without the chemo bit. So we were the first site in the world, and we've got 5 patients, including the first 3 were the first 3 in the world. We also opened a study called NAV1003, and the first 2 patients were the first 2 in the world, which is pretty cool for us in Adelaide. Nothing much sort of seems to happen, but we were quite excited about doing completely new things. We've opened a triple negative breast cancer study. And again, we're the only two patients in Australia are under our care. But we're also looking at early stage breast cancer. So we've opened a study called Lidera, and we're the highest recruit in Australia, the second highest in the world, and hopefully we'll beat those guys in France too. So what's the future? So the hope is to get cutting edge medicine, which is what we're trying to do, collaborate as much as possible. We also want to try and support people living in rural and remote areas. We want to try and look at support for First Nations people, but also want to try and see if we can try and get clinical trials for patients in their homes. So instead of them coming to us, can we sort of go out to them through telemedicine and sort of posting out, medicines and all to them? We want to get better adjuvant therapies and curative options. We will try and look at preventive oncology, but also want to try and look at biomarkers, both for prevention of cancers and also surveillance of cancers. We want to be the leaders in early phase oncology, so the first in human work, if we can sort of try and grab that niche. We also want to try and look at late line studies when people have run out of options. The bench to bedside, so the hope is we can work with Adelaide Uni and Uni SA as well as Flinders to try and look at the researchers from there, if they actually want to talk to humans and try and work with that. So we would try and help work that out. Want to try and get better metrics, but also research of various tumor types and mutations. But we also want to try and work with hands-on education. So for example, Adelaide University does courses on clinical trials and research. So we're quite keen to partner with them to actually give them the clinical bits of what it is. But we want to try and also generate a platform to start impactful research units. Down the track, we hope to set up a research foundation to try and help us out with education and training for different things. And I think for us, what we realize is the competition makes us faster and potentially more than what we are, but I think collaboration makes us better. So thank you so much for your time.
Thank you so much, Rohit, for that very brief but very incredibly interesting, I think, presentation on what you've achieved down there. Just let me have a look in the Q&A. I don't think I've got anything specific for you, but I was interested, well, in everything you said. This issue of sort of a poor base for actually people with skills in clinical research amongst clinicians. I mean, this is something that we, particularly at NALHN, one thing we really want to do is improve our capacity, and that really has to come through training people, who can conduct clinical research. I mean, do you have any suggestions about, how we might better do that? I mean, you suggested that the University of Adelaide has some courses that people can do, but either of you actually have ideas about how we can expand that better and encourage perhaps young trainees and young consultants to engage in research?
I think for us, I think the real way to get people across is to get them to get fellows, like research fellows,
right?
Or even people who are trainees who sort of are between jobs, not certain what they want to do. They could quite easily come along and work along with us to try and see what else is done. But I think there's huge amounts of scope in what's available. And whether it's through the uni or just sort of through NALHN alone or through other like I think things like SAMRI and the Adelaide Biomed precinct, I think they've got huge capacity and potential in what they can do.
All right, yes, thank you. I'll quickly squeeze in this question for you, Raj, from your talk. The question was about the rate or risk of having to change to open surgery when you're using an endoscopic technique for resection of a cancer.
Yep. So I briefly answered that online, but I'll give that a go. So basically, the most we get a 90 to 95% success rate, and it depends on the lesions which comes to us, because not all lesions are created equal, unfortunately. So there are some which are fairly early, but there's some where they're in the cusp. They could have been a little bit more advanced than initially thought. So occasionally, or most times, the ones which head off to surgery are the ones which pathologically it has been proven that they are either poorly differentiated or they are going a little bit deeper into the wall, into the submucosa, where the risk of lymph nodes are much higher, and surgery is recommended to also clean up, for want of a better word, those lymph nodes. So about 5%. The other issue is that acute complications can still occur, and that's a small subset of patients which need to head off to surgery. But having said that, most of these perforations can be recognized during the procedure and then dealt with right at the procedure itself, rather than sort of sitting on them and letting them go.
Okay, thank you very much. Rohit, maybe in the last minute we have, could I ask you, actually it was a question from John Beltrame, I think, and maybe you've answered it in the, but just the management of your research ethics and governance processes, how do you handle that in this independent centre?
So we sort of use Bellbury for all of our ethics and research work. They're absolutely brilliant, is the least I could say. And I think it's interesting, they're actually based in Adelaide, and I think they don't get enough credit for what they do. We've tried pretty hard to get Bellbury to sort of be the ethics for the public hospitals. But I think we've sort of haven't really achieved that till now. But Bellbury does a very good job. Not just do they help us, but they also actually advise us to what to do. We've got 2 people who do all the ethics and governance for us, and our turnaround time is extremely fast.
Right, right. Just last question. In terms of your referral base, I mean, I take it that referrals from the public system are also, people would be eligible for treatment through the cancer centre. You'd have a wide referral base, I would guess.
Correct. So the way we worked out this unit is that nobody gets left behind. So whether it's public or private or insurance, doesn't really matter what they have.
Right.
So we built contracts or budgets such that everyone can get treated, and the study actually pays for them to sort of sit and get treatment in the hospital. If it's an oral-based treatment or a subcut-based treatment, it doesn't matter at all anyway. But its main cost tends to be the hospital, using the chemo chair and the nurse, which is funded through the research work. So that's never an issue. But we've now got people coming to us from interstate. And we've also got one person from New Zealand, because we've got studies that nobody else has. So it's been quite a fascinating sort of 10 months for us about how to actually work it up in real time.
All right. Thanks to both of you for terrific talks. That was a really terrific session. Hats off to both of you for the work you're doing. And thanks everyone for joining. As I say, this session is recorded and should be available within the week for viewing online. So with that, I'll wrap up. Thank our 2 speakers and the audience, and see you next time.